First off, I want to just say that as a massage therapist, even though I have the CDT training, I'm still sort of limited in what I'm allowed to and what I can do. For one, I cannot offer to work with people's insurance. Um, for people to run through insurance, you have to do it under a physical therapist. So everybody that comes to see me, they pay out of pocket. Now, personally, I think they get a little bit more for what they pay here. And the reason for that is that most of the lymphedema facilities that they go to, or clinics that is associated with hospitals or physical therapist offices, they have somewhere between 45 and 50 minutes with a client. And that includes assessing them. And if they're in treatment, which we call the intensive phase of treatment, which can run from like 2 weeks to 8 weeks and sometimes multiple sessions of 8 weeks, they do unwrapping the bandages, assessing the skin, seeing if there's anything that needs to be addressed there, such as wound care, creatones, any kind of damages or something. Then they do a session of MLD, and then they rewrap, and then they also do exercise training, and they also do education for both the patient, but also usually for a family member. So they have 45 to 50 minutes to do that. And as Jeanette mentioned before, an MLD session that takes 15 to 30 minutes, it's not the same as coming to someone who does 60 minutes. When I see my clients here, I do 60 minutes of MLD, and then whatever time it takes to bandage or unbandage. I usually put aside 2 hours for each client that comes to see me because I want to make sure that I have enough time for them. So things that I have to think about when I see them is that I cannot do wound care. And if there's any kind of complications such as cellulitis, which is a very, very contagious and actually dangerous disease because it spreads crazy, and you have to get treatment right away. It gets very inflammatory. It's easy to spot though. So those are things I can't do. I'll have to refer out of my practice. Things I can do is that I can bandage people, and I use special kind of bandages. The ones you probably know are ACE bandages or long stretch. They stretch really far. The ones I use are short stretch, and they stretch not very far. And the reason for that is that we're trying to achieve a specific kind of compression within the bandage that we do. So we're pushing fluid from the most distal part of the limb up into the to the region closest to a safety zone or border. So that's what we do. MLD is, as Jeanette said, is a very specific kind of sequence where we're trying to reroute around the compromised lymph node clusters that cannot receive lymphatic fluid. So we're trying to reroute around it, and we have to open up all the other areas and open up like you do, open up the terminus. We teach people how to do diaphragmatic breathing exercises. We talk about exercise in general. Once we're done with an intensive phase, I take measurements with these special little measurement tapes, and then we kind of recommend different kinds of compression garments, and there's a lot of different ones. So we work with different compression gradients. I think it's backwards, but you can kind of see that they're different kind of gradients. This is how much pressure something is putting on, and it has to do with how likely is the fluid to flow back into the limb that we just treated for a long time. And that's very different from person to person. It has to do with how well or not well their lymphatic system is functioning. So that's one of the things that you have to know about. You can also do special kind, I haven't taken this class though, but I really want to, special kind of kinesiology taping for lymphatics. We're more familiar with it in massage therapy world for sports injuries or muscle that are cramping or under any kind of stress. So that's one of the things we do. As a CDT therapist, you also have to be familiar with what you can and cannot treat. So for example, lymphedema benefits from this kind of treatment. So does plastic surgery recovery. Lipedema sometimes benefits from it. You cannot treat people who have cardiovascular disease. You cannot do anything with heart failure. You can't do acute DVTs, obviously, so you need to be very good at spotting that, because you can imagine if someone has a really big limb on their leg and they're not walking, then they're more likely to get blood clots, like we've been talking about being bedridden. You cannot treat someone with active cancer unless the doctor kind of prescribes it, and then you have to be in really close contact with them. So things that we do also when we're doing the bandages is that we're using different kinds of foams. This one is a very firm kind of foam. This is a little pat. This one goes on the hand or around the ankle. Other foams that we use are these kind of gray foams. These go inside the bandages and have different, this one's a thick one. There's a thin one too. These go inside the bandages and we have to be able to cut them to the specific size of the client. If people have a very big, we call it lobule, but like a big hanging piece of skin and tissue, you have to be able to kind of tie that up and do everything with that. Our intake forms are like 4 or 5 pages compared to the one we know from massage therapy and the one we use in oncology massage. So it's a lot of information you have to do with, and I always am in contact with people's doctors, because even if they come for me for treatment and feel like their insurance copay is as expensive as coming to see me and they get more out of seeing me, I am not a doctor, I am not a nurse, I'm not a physical therapist. I have to work within my scope of practice, and the best way to do that is to communicate with the other people that are in their care team. So that's a lot of the things that I do here. And you can see this is my stash of all kinds of equipment. Now, I don't actually give these away. People still have to buy their own sets of bandages, which is about $200 for 2 sets of bandages for an arm or a leg. And they have to wash them every time they come in. I have these here as spare parts. If something should happen to break, they can get one from me. But mostly they buy it themselves. And we're talking about the compression garments, just really quick, and then I'll finish. This is just one magazine. This is Medi. And they have so many different kinds in here of compression garments. They have different colors, different sizes. They have capris, they have legs, they have just feet. They have all kinds of stuff. The same thing for arms. Some brands are better with customs, and some brands are better with just standard sizing. Some brands are really good with what we call the reduction kit. It has like Velcros on it. And some are not. So we have to know a lot about the products that we're recommending. And they're expensive. You need 2 every year because you need to have one that you can change out. You need to wear a compression garment 23 hours a day. So you have 1 hour to shower and dry off and put lotion on. And then you need to wear that compression garment. There are 2 kinds of compression garments that they have to invest in. There's one that you wear during the day, and then there's one that you wear during the night. And the one they wear during the night can be the bandages, which is why we teach them how to do it, or they can buy special garments that is like a sleeve that they put on, and it looks like a huge oven mitten. One custom garment is about $700 to $800, and they're not always covered by insurance. So it's an expensive condition to deal with and live with for the rest of your life, which is why, as oncology massage therapists, we really do not want to be the ones who trigger this. We want to be the ones who they can come to for safe massage, and be knowledgeable about what we do with all the clients that come to see us. So does anybody have any questions about what I do or what CDT is? I'd be happy to answer anybody's question, and it's easiest if you just unmute yourself and ask.
What school did you go to?
I went to Norton.
Okay, yeah, I looked it up last year. Yeah, thank you.
Michelle, what I'd like you to explain is, I understand things are different now because of COVID, but I'd like you to revisit the conversation that you were having with your hospital and the role that you were going to be playing with them as support CDT therapist, and why that role was important to the hospital.
So I work for Mercy in their infusion center, and Mercy is part of Dignity Health. Dignity Health does have a lymphedema clinic in San Francisco, and I'm in Sacramento. So what they have been doing so far is they have been referring their clients with lymphedema out to Kaiser and out to UC Davis, which is really expensive for them to do. There's also a few private practices in the area, but not many. So when I took my classes and I then contacted the wonderful lady, Rachel, who has been the one running the infusion center program, who was the one paying me and setting all that up, she was like, that's amazing, we want to have a contract with you. So the contract that we have is that I have a special price for them if they buy a minimum of 3 sessions a week for their clients, and that's because that is my minimum. I recommend 5 days a week of treatment, but I understand that most lymphedema clinics only do 3 a week, so that's the minimum that I'm willing to do, because otherwise it just doesn't work. So they purchase via me sessions for their lymphedema patients, and Mercy is a wonderful hospital that actually pays for their patients to get these treatments. It is regardless of their insurance, but of course if their insurance cover it, that takes precedence first, and their insurance usually determines where and how they can receive treatment. So if their insurance says it can only be done by a physical therapist, they can't send them to me. But the contract that we've set up is that anybody who is outside of the insurance system, or that the insurance system allows, they're going to start sending them my way. So I'm going to have a great contact with Mercy there.
Thank you so much for sharing that.
Yeah, welcome.
So the reason I asked Michelle that question at the end is I wanted to reinforce for you how few CDT therapists there are available out there. There are so few therapists available that a hospital has to contract that service out to a qualified massage therapist to be able to fill that need. So as massage therapists, as estheticians, you already should have a resource list of some sort that you refer clients to. If someone's looking for a dietitian, if someone's looking for an acupuncturist, or if someone's looking now, as this world opens up to you, if someone's looking for an MLD certified or CDT therapist, building that type of professional resource list is important for 2 reasons. Number one, you can provide best care practice for your clients by being able to refer them out to people who actually can help them, who are qualified to help them. And with regards to oncology, I think that the 2 most important referrals I would earmark for you to find in your area are acupuncturists and then MLD, CDT. And if you're a massage therapist, you should also find an oncology-trained skincare therapist. And vice versa for the SDs. So the most important reason for you to have that resource list available is so that you can appropriately refer clients out. And then a second very valuable reason to have that resource list available is you create relationships of referral with those other professionals. Because by having somebody on your resource list, it'd be important for you to introduce yourself to them so that they know where patients are being referred from. And then all of a sudden they have a contact that they can refer patients to when they're looking for a safe facial or for a safe massage.